All right, I'm going to go ahead and begin. I'm a neurologist. When I gave this talk for Dr. Stefani, I said it's an embarrassing time to be a neurologist. My son, in May of last year, developed double vision and a facial weakness. He was hospitalized for 3 or 4 days, saw 3 neurologists, had all sorts of tests, was diagnosed with ADEM. So I have not been in the MS world. I went straight into research for the last 25 years. And so I said, wow, great, they've made a lot of progress since I was a resident. Well, no, they hadn't. So in December, he then developed ascending numbness up to his chest, and he was diagnosed with MS. So I decided it was time for me to catch up on literature. And what I discovered was that no progress had been made. And it was my wife who said, well, you should be reading about this guy who makes ice skating rink devices. And I said, no, this is too crazy to believe, but she was persistent. And so here I am today. Basically, to jump the story forward, I went to the Hamilton conference that Mark put on, met everybody, spent several days with Mark in Wayne State, learned his method of evaluating the Haacke protocol, brought it to San Diego where I run an fMRI facility, so I had the same scanner that Mark uses, a Siemens 3T, that is also able to do SWI. And sure enough, we sent the images to Mark. Sure enough, my son had obstructions, so I found an interventionist. I found one that was very experienced, but did his stuff at a very small hospital that had a very weak neurology department. Arranged to have my son done. My son had severe obstruction of the jugulars and the azygos. All the symptoms went away, even symptoms, something called a Lermite sign, kind of an electric shock that goes down the back when you bend your neck. Also, his personality totally changed. He was really an asshole for several years there. We actually went all into group therapy together because he was just so inappropriate. He's now, a number of you, I believe, have spoken to Devin on the phone or by email. Just a totally different person, outgoing, easygoing, stress doesn't bother him anymore. And then my next challenge, of course, was to get IRB. This was right around the time that Mark was having trouble getting his IRB. Dake had been shut down at Stanford. So I decided I really needed to put on my Machiavellian hat and figure out a way to get an IRB. So I went to the same smaller hospital that didn't have a strong neurology department. And I came up with an IRB that was not confrontational, was not too fancy. And we were able to slide right through. So in June we got IRB approval. So now we've now done maybe 30 of the Haacke protocol, and we've done about 15 treatments with the IRs in San Diego. So I want to go through with you this literature. So the orthodox, what I was taught 25 years ago, and what the neurologists are still telling patients today, is that MS is an attack by the immune system on myelin, right? That's what autoimmune means. It means that the immune system thinks that myelin is a foreign substance and is attacking it, right? That's what we've all been taught. So let's just talk about that. First of all, the viral theory has not been validated. The autoimmune theory has not been validated. You don't sort of hear that when you're talking to a neurologist, but if you look at the literature, and I'm about to read you 2 devastating quotes from the literature, the medications are marginally effective. The neurologists pride themselves in their huge trials. Think about it. Why do you need a huge trial? It's because the effect is so small that in order to get enough power, you have to do huge trials. Right? It's not a good thing that you do huge trials. It's a sign of the weakness of the method that you have to do huge trials. And then it's dangerous, right? We know Salbury's dangerous, but all of them are. These medications, they call them disease-modifying drugs. These are immunosuppressants. They would use steroids if they could. Right? You can't use steroids chronically because of the side effects. So these are drugs that are basically trying to be like steroids, only with less side effects. That's what they're doing. They kill white cells. Right? That's how they're working. Right? So let me read you, this is from the main textbook. This is the main textbook on MS. I'm going to read this whole long thing because it's so devastating. The possibility of being in a primary infectious process with or without an associated autoimmune reaction has not been entirely ruled out despite repeated failure to identify a causative agent. Over the last 4 decades, at least 14 different viruses have been isolated from the brains of MS patients, yet none has been shown to be etiologically related causative. Cook listed 22 agents suspected of being related to MS, for which substantial evidence of a causative role has not thus far been appeared. This is from a prominent researcher at University of Glasgow. This is published this year. These significant data seem to have been ignored by some who are willing to defend the theory that MS is an autoimmune disease mediated by immunopathological mechanisms, despite overwhelming evidence to the contrary. Studies of these agents showed that the inability to go beyond the 33% line raised the possibility the entire observed benefit is only a placebo effect. It can be argued that over the years, the autoimmune hypotheses have been harmful to a considerable number of patients. Basic studies on speculative immunological mechanisms are continually shown to be It is clear that modern research should move away from the autoimmune theory. So what is the Zamboni theory? The focus for the IRs, of course, is on the cool anatomy, or the wild anatomy. Right? I mean, that's the problem, right? The venous system is so variable. Think about the veins that you can see on your arms. Everybody's veins are a little different. Even on your 2 sides, they're a little bit different. That's been part of the problem. That's why I never even heard the word azygos in my medical training. We didn't care. It's like, who cares about the storm drains in your street, right? You care about the water supply in. You don't care about the drain. As long as it's not stopping up your toilet, who cares about veins? I think in general in medicine, part of the problem we've had is we just didn't pay attention to veins. They were sort of, the leftover stuff. So everyone is having to go through this education. The IRs are way ahead of everybody else. And I remember not so long ago looking at Mark's images, and I couldn't tell the jugular from the vertebral, from the external jugular. It was just very confusing anatomy. So that's part of the challenge we have. So that's the anatomy. But what's the theory? So what's he shown basically? He's shown that Doppler and MR venography have obstructions, right? Now the debate becomes, well, more than in normals, and so far that's still going on, right? Zamboni basically found 100%. Zavadanoff at Buffalo is sort of aiming more in the 55, 60%. This guy in Germany, his name is Dope. I mean, it's just not a great name. D-O-E-P-P, right? He found none for the reasons that Stefani mentioned. So there's going to be that issue. What percent is? So that's the first thing Zamboni is. He found a lot of abnormalities that no one expected. Then he treated some of them, and a whole lot of people got better. So that's the second debate. Well, how many are going to get better? How many are not going to get better? That's an issue that we're still going to have to figure out. What is the theory? So his theory, and I think this would be Mark's theory too, but give him a chance to put him on the spot there. Backflow causes damage to the small veins in the central nervous system, which leads to leakage of red blood cells and iron into the central nervous system, which leads to inflammation. Now, I think that's the theory, but I don't really feel that theory has been really carefully articulated yet. But that's basically what my understanding is, that delayed flow is putting pressure on the venules. So you have arteries, arterioles, capillaries. Capillaries are so thin, literally one blood cell goes through them at a time. And then they widen, that's called a venule, and then they become a vein. So the MS, the neurological symptoms are not being caused in the neck. They're being caused in the central nervous system, in the cortex. So the big vessels aren't there. It's the venules in the white matter and the cortex. That's where the damage is being done. So red blood cells leaking. The endothelium is weakened. The endothelium is the lining of the vein. It's weakened. Red cells get through. Iron gets through, and then that incites an inflammatory response. I think that's reasonable, but that's not what my own theory is. I think that in fact what's happening is that You don't want a swamp. You don't want a stagnant swamp in your brain. Those cells need to be clearing their environment out continuously. You don't want the debris you want your toilet flushing, right? You don't want to leave that environment just sitting there. And a slowed, swamped, stagnated environment weakens the oligodendrocytes. The oligodendrocytes are the cells that make myelin. That because the oligodendrocytes are weakened, perhaps there's too much nitric oxide, perhaps there's leftover neurotransmitters. Glutamate has been accused of being a toxin to oligodendrocytes. The myelin falls apart, and the white cells are coming in to clean up the debris. That's actually what has been shown. There's a scavengering going on. The white cells are not coming in to attack myelin. The white cells are coming in to clean up myelin that is fragmented and been damaged by a stagnant swamp. So there are different theories, but I think this is the challenge for neurology going forward. Is okay, we see these obstructions way out peripherally, but what's that doing to the brain? Why is this pathology actually happening? So I run an fMRI lab, and this whole thing feels so impossible to explain coincidentally. What was I doing running an fMRI lab when my son gets diagnosed with MS? So what is fMRI? So fMRI is, instead of taking a snapshot of the brain, it takes a movie of the brain. You get an image every 2 seconds. And so you can see thinking. You can see cognition. So when the brain is activated by a task, looking at something, doing something, those neurons call in extra blood, a surge of blood that comes into the area in order to feed the brain, which is now doing a task. So you get these very detailed images. I'm going to show you this picture in a minute. How it works is that the MRI can see the difference between hemoglobin, which has iron in it, and hemoglobin, which is oxygenated, and hemoglobin, which is now deoxygenated, and it's now in the venous system. So that's how fMRI, it shows that difference. So just to give you one example of what we used to do, what we do, I was interested in meditation. That was one of the things I studied in fMRI. And so this is kind of a cool image. It shows you what you see. When someone's meditating, what do you think is going to happen? Do you think their brain's going to become very quiet? Do you think their brain's going to become very active? Or something in between? What you actually get is the attention area, the frontal lobes. This is the front of the brain, back of the brain. Vision's back here. The executive function is in the frontal lobe. You get a quieting of the attention area in the brain, and you get an activation in the insula. The insula is where we feel sensation from inside our body. So it's where the research in fMRI is where you activate when you feel love or feel compassion. So it's kind of nice that when someone's meditating, you have a quieting of the attention area and an activation of the compassion or love area. It's sort of fun stuff to do, but it's an image of what you get. So I reasoned that maybe a test, this test, the fMRI test, might actually have a role in looking at venous drainage. And the reason is, one of the professors at UCSD, where I trained in this method, Buxton, he had the balloon model. So his idea is arterial flow comes in, and when the cognition is calling in for activation, there's a surge of blood in, and then it goes back out again. And so it surges in, then it comes back out again. But during the middle of that phase, the venous supply dilates a little bit, it balloons a little bit. And so you get a pattern that has been recognized for about 20 years, which is you see an increase in the blood flow, the surge of blood in, then a plateau during the task, and then it drops down. And this is what down here is called the venous undershoot. So this has been recognized for 20 years, well, 15 years, that you do have this venous undershoot in the fMRI signal that needed to be explained, and it's explained by the delay in the flow, the venous flow of blood out of the brain. So I thought maybe this would be a way to have another way of testing this. So I came up with a task. It's called the tell time task, where basically you hear a time of day, 2:30, and then you see two clocks. One says 2:30, one does not say one says a different time, and then you have to choose which was the wrong clock. So it means I'm getting a look at the visual cortex, I'm getting a look at the auditory cortex, hearing it, I'm getting a look at the two motor areas when you move your hands, and then I'm getting a look at the executive area because you have to choose the wrong answer. So it takes effort to choose the right clock. You have to choose the wrong clock. Well, this is what we got. So we've now done about 20 of these, but I'm just going to show you one. So on the right, this is the pattern that I showed you. That I showed before. What you expect to see is a steady increase in blood, a plateau, and then it drops down, and this is the venous undershoot. With the MS patient, you see a significantly greater peak, and then it drops down almost twice as far, so the normal is -1, the patients are -2, and what we discovered is it also goes out further, so I'm going to show you that in the next slide. The venous undershoot is twice as deep, and it's also much longer. So this is now, we've now done, all of our patients have this test done before and after they have angioplasty. So I guess now we have about 20 of them. So this is what the actual MRI looks like. This is not the hemodynamic response. This is just actually what the scan looks like. But even looking at this, let's just look down in this area here. So this is before angioplasty. That's after angioplasty. So there's clearly a difference, but the dramatic effect is in the hemodynamic response. So this is pre-angioplasty. This is post-angioplasty. This is the prefrontal area. That's the executive function. That's the inhibiting the desire to give the wrong answer. Precentral is where the motor task is. The parietal and visual is picking up the looking at the clocks. And it is obvious that the venous undershoot in all regions is much larger before angioplasty than after angioplasty. There's basically a little tiny bit there, but all the rest of them, clearly one can see a really dramatic difference. So I'm actually optimistic that this actually might be another way to evaluate the problems we've talked about today. So which type of abnormality is significant or not. The vessel being a little bigger, a little smaller, the flow being difficult to measure. I'm hoping this might be another way to do it. Because it's actually measuring the cortex directly, right? What we've been talking about so far is measuring the veins in the neck. But of course, what we really want to know is what's the brain response? Is the brain getting cleared out adequately or not? So this hopefully might be a testable way to do it. It's obviously non-invasive. It takes 15 minutes. Of course, what it doesn't do is it doesn't show the location of the obstruction. And then also, it doesn't evaluate the spinal cord. So it's how I'm working on pursuing this issue. Okay, I'm not gonna. This was a guy at Wayne State. This guy is impossible. I'm just not going to read it. The one in Canada was mentioned earlier. He's the one calling it a hoax. What's going on here? You know, I really don't quite get it. Why the neurologists are, number one, not intrigued, but why are they so hostile? It's really, I don't really get it. You know, my joke is, I thought we were the smartest guys. Neurology in general is very difficult in medical schools, very difficult, so the arrogant, really smart guys tend to go into it to sort of show off that there can be better medical students. Well, we're not seeing that today. We're just seeing, it's gutsy to call other doctors quacks. That's gutsy. You know, just layman, that's maybe not such a big deal. But for an MD to call another MD a quack, especially one that's been published in refereed, solid journals, this is an emotional response that I don't really entirely understand. There's not been one paper in the Academy of Neurology yet. There was an editorial from the guy at Wayne State, Omar Khan, just saying it was experimental. I wrote him an email 3 months ago and said, okay, you're saying experimental, but do you have any actual substance and argument against it? Is there some finding in the virology literature or in the looking at the lesions under a microscope that makes you say it couldn't possibly be vascular? There's been no argument like that. There's not. I keep waiting for some neurologist or some researcher to say, well, gosh, you guys don't know that this has already been settled, and that's why this is an impossible theory. That's not the argument that's being given. The argument that's being given is, it's so different than how we've been looking at MS, even though these people know that the viral and autoimmune theories have not borne out. So I mean, it's very surprising to me. But look what's happened. This is what's happened. The internet, right? Joan Beal, Diane Gordon, famous names. Amber Alstott, sitting up here on the front row. They all sort of have their favorite sites, you know, Facebook versus This Is MS versus Ning.ning, whatever that site is, CCSVI locator, Ken Torbett. Hey, you thought Ken might be here. He's not here today, is he? Oh, Dr. Dake's on the 14th? I mean, it's amazing. I mean, it has changed the doctor-patient relationship, right? You've heard these stories of people bringing in the journal articles and relentlessly haranguing the physicians. This is really, really amazing. Okay, so there are definitely some major things we got to figure out. What percent really have it? So there's been a debate, 100 to 60, and now you have this guy in Germany saying 0. I believe Zamboni has already written a rebuttal to this, but it hasn't been published yet.
I believe it's not accepted for publication. Basically, what Zamboni wrote in this very short article was that, in fact, the data that's in Bo's paper that he's published, a table showing what happens to patients, MS patients, when they go from lying down to sitting up, actually validates the CCSVI theory. Even though they wrote that it didn't validate it, they didn't understand what they were looking at hemodynamically.
All right, so obviously we need to know what their true percentages are. Another key question is that everyone has been alluding to, which is the gold standard is the catheter immunography. What is going to be the correlation between that and whatever the testing is? So right now, at least in my mind, I do the Haacke protocol. I always call it that because that's not just an MRV that any MR suite can do. These studies that Mark's group do, they're sitting over there in the back of the room, takes them, when I was there, it was taking them half a day or longer to do each analysis. It's a very, very detailed analysis. We are doing it now, so I know exactly what that is. The flow quantification is quite time-consuming. So just getting an MRV somewhere, you're likely to have a negative study. As far as I'm concerned, I would not do it any other way than have the data be sent to Haacke's group. They have 10 of them up there. 24 hours a day is what it feels like, grinding away getting this data. But we're going to really need to know. So far, we've now done 15 patients with the IRs in San Diego. So I'm waiting for the one where I said, I called it positive. The Haacke protocol, I called positive, and they find a negative catheter study. That has not happened yet. I hope eventually we do. I think we have to push it so that sometimes the IRs are going to say, you know, your test was not perfect. When I went in and looked, everything was normal. That has not happened one time yet, but we need it to happen. Otherwise, we're not being aggressive enough. You want to have some negative procedures so that you know you're not waiting too long. I actually, Mark?
Can you speak to those somewhere between 15 and 20 cases that have been done? Can you say a few words about what they have found?
It's a placebo. I don't know why you asked that kind of question now. All right, so let me finish my point on this. So far, of the 20 that have been done, every one of them has significant pathology. So as far as I'm concerned, the Haacke protocol has been accurate in saying there's pathology and it being found on the procedure. I actually, Mark just sent me an email last week and said that 25 of 27 had abnormal MRVs, but only 7 of 27 had severe reflux. To our read, only 2 had no reflux. So if anything, I think I want to be highly sensitive. I want to err in the direction that we go in and find nothing. So if I see even a little bit of reflux, or even just going to 0, just stagnation, I'm going to send them on to my IRs. Maybe down the road I won't. Maybe down the road I'll say, no, that's going to be a waste. It's going to be a wasted procedure. But since I haven't had one of those yet, I'm going to go as aggressively as I can. So from my point of view, if the venogram shows normal-looking vessels and there's no reflux, but one vessel goes to 0, that's good enough for me. That's enough of a reason. It's an abnormal study. It's enough of a reason for me to justify that I recommend a referral for catheter venography and if positive, venoplasty. Other sources is going to be a problem, right? We focused on the lower jugular and the azygos pretty much so far. There's an ongoing debate that was fascinating in Brooklyn about the upper jugular, whether that's just collapsing on its own or whether there's actually stenosis there. That's going to be great stuff to be following over the next year or two. But what if it's higher up? What if it's above the jugular, the sigmoid sinus, the transverse sinus, the straight sinus, smaller vessels? Is it possible that you can have stenoses in the thalamic vessels themselves? We just that's going to be an area that we don't know yet. And then certainly another question that we have to deal with is how do you objectively recognize restenosis? Clinically, it hasn't been hard at all. So what I do is anybody who thinks they've had a restenosis, I get on the phone with them before they even talk to the IR, and I listen to the story. Neurology is a lot about listening to the story, and so it's really quite clear when someone says, this is what got better, and sometimes it can be my foot changed color. Not everybody is having a dramatic change, but my brain fog got better, my headache got better, I'm still using a cane, that didn't change, but now all those symptoms have returned again. If I hear that, then I'm going to talk that over with the IR that did the case, and I think he's going to be willing to go back in. The other alternative is we do some additional testing. We do another MRV, maybe we do the fMRI test. There could be situations where we have to kind of make a call. Do we go right back in and do the catheter procedure again, or do we want to do a little more testing first? So far, it has not been a problem. The people who called me thinking they had a restenosis, I did not think they were. I think basically just had not had as much of an improvement as they hoped they were going to have. That's another question, by the way. It seems like people continue to get better for quite a while. There's a dramatic change right on the table or that day, but then it seems as if over the next weeks, even as long as a month, people continue to get somewhat better. So I think a question we're all going to have is permanent nerve damage versus what I'm calling compromised nerve. So I believe if the axon has been killed, if you've had the demyelination long enough that axon isn't dead, that's just doesn't seem possible to me will get better. But we're seeing people that have improvement in neurological symptoms. So that says to me there must be kind of a compromise to the nerves, that even though they're not dead, they're weakened, and by improving flow, by improving the stagnation in the swamp, that gets better. I don't see any other explanation. Some of the symptom improvements have to be vascular, but I can't see another explanation. Mark, of course, has an explanation for everything.
No, I've just been reading some interesting papers very recently. This one paper was on a set of rats. One group had diabetes, and one group was hypoglycemic, just speaking about glucose. And what they found is that when you reduce blood flow to the nerves, nerve function reduced accordingly. So it was very interesting. They took these diabetic rats who had malfunctioning nerves, and they increased the blood flow, and the nerves started to function properly again. The hyperglycemic rats, when they started recovering, the nerve function recovered again. So in fact, it's almost like the system was going into hibernation. Maybe it's not being totally destroyed yet. Obviously, that would depend on how long you've had that problem. But the good news is that it seems like when you return the flow, you return the function. And sort of our pet rat, which is Steve Garvey here, is perhaps a very good example where on the table the blood flow returns and the nerves actually start functioning again. So he moves his hand. So I think we don't know how much damage is done over a given period of time. That's right. But there is evidence that flow is related to nerve function. Yeah.
So I think this is one of the ones we're going to have to sort out so that we are not having that we can set expectations properly. What's likely to not change, what is likely to change, these are the things we're going to have to sort out. And then Simca sent us all an email this morning raising this point again, that the story is not going to be over once we relieve the large obstructions in the jugulars and azygos veins. On my model of it being more of a stagnation issue, that says to me there must be something that's hanging around in the extracellular, around the neurons, that we need to know more about, nitric oxide, glucose, something else. And then, can we do things for the endothelium? So there's all these, this internet world is way ahead of the medical profession on looking at vitamin D, low-dose naltrexone. There are medications out there that are used for varicose veins. There's probably going to be a role for something where we try to strengthen the endothelium, clean out the swamp, in addition to simply removing the big blockages in the main storm drains. And then, there's something going on with the genetics, so that we have to kind of sort out what's going on there. I didn't tell Mark this, but I ran my wife and daughter as normals. Neither one was normal. And they all had exactly the same finding. My son's was much more severe. It was the same size, same location. So that's going to be. They both of them have severe fatigue. So they don't have MS. They don't have gadolinium-enhancing lesions or neurological symptoms. But they did not have normal studies. So getting more normals is critical. It's tough because it's hard for me. It's hard to convince a normal to give them gadolinium. It's a lot to ask of a friend. Mark, when you come in September, you can be a normal subject.
I'm definitely a normal subject. But this is an interesting point, because remember Zamboni's study? They did 500 cases, and I can't remember if it was 250 normals and 250 MS patients.
And that was Doppler, wasn't it?
And well, they did MR2.
But it wasn't the Haacke protocol, right?
Not completely. But basically what they claimed was they found 22% of the normals appeared to have the Zamboni criteria. Well, it turns out that they used age-matched relatives of the MS people. So in fact, I don't say this negatively, but they were criticized because they did that. And from what you're saying, if this is genetic, or even if it's a 20%, it might explain why Zamboni found 0%, because he didn't use relatives of those people when he did his normal. But Savadinov, they used those relatives. So maybe it's not a surprise that they found 20% might have similar things, basically just the way you did with your wife and your daughter.
Well, it gets worse. My wife wants to have the procedure. So I said, I am not going to tell my IR, who I dragged into this mess. I sort of snuck it on him. And now he turns out he's a friend of Dake's, so he was not totally ambushed by me, but I was trying to ambush him, right? I was trying to get him to do my son, and then I got him on the IRB sort of before the politics really went crazy. And now he's totally happy he's doing it. He's happy. All these IRs, all IRs are loving this, right? Their last cool disease was hysterectomy, was uterine fibroids, which was Dr. Stefani's last winning war. Okay. So what do I tell her? So I had her go to see a cardiologist, and they're sort of working through. He had never heard of this. He says, "You don't do IR on veins." So here's a cardiologist who didn't know you could even do it on veins. So he's having to work through that. But they're saying I have severe fatigue. Isn't it possible that I'm going to end up with a MS lesion someday? So I think fatigue is going to be the final battlefield here. It's not going to end with MS. What if it turns out fatigue is not a psychiatric symptom? Right? And then the viral autoimmune theory, at this point, that's the hoax, right? 40 years of research has come up with nothing. Billions of dollars of research, so they got nerve calling this the hoax. The drugs are, there's the false hope. These drugs don't work very well. So this really is the most exciting thing happening in MS right now. And the neurologists are on the sidelines for reasons that I still don't really understand. Everyone should be getting involved with this. Everyone should be studying this. And there's no way around studying it but to have people have the procedure, to find out what happens, find out which veins, find out who gets better, what doesn't. Everyone should be risking false hope, risking letting people go in there and not be helped. The second patient we evaluated, the husband, I said, well, you know, I understand neurologists don't want to give people false hope. The guy punched me in the chest with his finger. He says, who do you neurologists think you are to be not saying this, that false hope is a bad thing? You know, how about any hope, right? What's weird about neurology is we specialize entirely in untreatable diseases. We're the ones that have no hope, right? So we just got to get out of that attitude and start helping these people. Thank you.